Welcome everybody to this virtual breakout session. I'm Michelle Stelzer, and we're thrilled to have your presence here to share, learn, and grow as we explore a valuable consult team, the palliative care team, with the single ventricle care. We have some incredible experts present today working in the space, representing a variety of teams and centers, including, most importantly, the patient and family experience. Next slide. We understand that life with chronic illness and the medical and surgical interventional trauma is a reality for patients and families. Some topics today may trigger emotions that may surface from hours, minutes, years, and decades ago. We remind you to take time to put your own mask on first, pause, step out of the room if you need, and most importantly, take care of you. We in SB1 value the lifespan experience. Next slide, please. In 2025, Lurie and Stanford had an opportunity to share perspectives on single ventricle programs throughout an invited lecture series. Meaningful conversations about variation in palliative care resource teams locally, across centers, particularly with SB1, stimulating an ongoing discussion during a pivotal time that SB1 was merging from NPC and FON and the Lifespan Registry. One important area of discussion centered around integrating palliative care teams across the continuum of care, beginning from prenatal, neonatal periods, and extending throughout the single ventricle journey. NPC-QIC introduced a single comfort care variable into the clinical registry in January of 2016. Although the available data remains very limited, with 103 of 220 respondents selecting comfort care, this early signal reflects a growing awareness, even a decade ago, of this importance of supportive palliative care services for patients and families navigating complex care. Importantly, this creates an opportunity to not only better understand the utilization of comfort care, but also broaden the scope and inquiry towards a larger umbrella of palliative care services and the many supportive elements as they integrate with interdisciplinary teams across prenatal, postnatal diagnosis, across a lifespan of care, and multiple points of access for patients and family and teams alike. Next slide. Kelly?
Yes. So today's session will include, if you could just go back one slide. Today's session will include a palliative care overview by David Mauser and Michelle Brown. We'll then share two centers' experience from both Lurie and Stanford Children's. We are then so fortunate to invite a parent perspective by Cassandra from Lurie's team. We'll also have a quick discussion and Q&A by Erica Mejia and Michelle Stelzer, and then some closing statements. And before we hand things over to Dr. Mauser, we want to start with a question for all attendees. Next slide. What one word do you think of when you hear palliative care? And this will, I believe, end up as a word cloud.
Install them here. Okay. There.
Okay, so I believe we share, scan the QR code and follow the prompts and type in what one word we think of when we hear palliative care. The magic of Slido will put together a word cloud for us.
There you go. Okay.
We'll give this just a few more seconds, since I know we have a jam-packed agenda here. It looks like comfort, support, holistic, guidance, choices, empowerment.
Advocates, Grace.
Grace Knowles. Just kidding. Shout out to Grace.
Dignity.
Bridge. Oh, that's great. Dignity Advocates.
These are great.
Yeah.
Give it about 15 more seconds
Keep
and
it
we'll leave.
sharing. Yes.
This is wonderful. Choices, decision making. Fantastic. Next slide, please. And then we have another poll for the clinicians and providers here in the audience. When do you engage with palliative care in relation to single ventricle care? And please feel free to select all that apply. Do you engage palliative care at the time of diagnosis, if complications occur, at transplant pathway, for end of life care, or none of these items? Give this just a few seconds as well. And these questions will also be at the end of our discussion today, just to see if there's been any changes. So it looks like lots of team engage if and when complications occur. Okay, next slide, please. And at the time of diagnosis. So very pleased to introduce Dr. David Mauser and Michelle Brown from my team here at Stanford, who are incredible members of our pediatric palliative care team. Dr. Mauser and Michelle, take it away.
Thank you, Kelly. Next slide. So as there are many people from the cardiac world, different disciplines, as well as patients and families, we just wanted to do a brief introduction of palliative care. So really what palliative care does is address, prevent, and identify suffering in children with serious illnesses, as well as their families and the teams that care for them. It's interdisciplinary in nature, meaning we're embracing physical, emotional, psychological, social, developmental, spiritual, and cultural elements of care, really focusing on quality of life for the child and support for the family. This can include goal-directed decision-making, management of symptoms, advanced care planning, and care through death and bereavement if that is the path that a child is on. It's appropriate at any stage of serious illness, though, and can be provided together alongside disease-directed therapy, which we'll talk about more in a second. Next slide. We have 8 main domains of high-quality palliative care. Just to name a few, so structure and process of care is really about operationalizing palliative care amongst different care locations, so inpatient, outpatient, home, as well as really finding the right clinician for the right patient at the right time. And I want to add that in addition to psychologic aspects of care, the developmental approach is really important in the pediatric space. Next slide. So you might see that similarly to our domains of palliative care, there are also these it's a holistic approach to this idea of total suffering, and really that suffering is such an individual experience for the child and by proxy for the family, that is about the whole person care, really aligning with all the domains of palliative care that we attend to. And knowing that it can't just be about the physical symptoms, it really has to be a whole person approach to managing and addressing quality of life. Next slide. So some of the ways we can tangibly help are we can help families better understand their child's illness, communicate with their care team, manage distressing symptoms, cope with spiritual distress, navigate complex healthcare systems, and ask those questions of what if. Next slide. There are a lot of myths with palliative care. I was so heartwarmed to see the word cloud and the timeline of when to involve palliative care, but really palliative care is not the same as hospice or traditional hospice, and it's not the same as giving up hope. We really align our hopes with the family's hopes and really live by this hope for the best, prepare for the rest mentality. The child does not have to be terminally ill or at end of life. Again, it's not prognosis dependent, although it does need to have, the patient needs to have a serious illness such as those with single ventricle heart disease. Because of the provisions of concurrent hospice care and also just the approach of palliative care in general, we are alongside disease-directed therapy, and we are supplemental, an extra layer of support from the primary teams, and so we don't replace anyone. And then finally, not everyone wants to be home at end of life. So a lot of times when we're called in late, it's to, transition solely to comfort. And really our job is about aligning the care preferences to the patient and family. And some people need that support of the hospital when things are really, really, really tough. Next slide. As I kind of said, there are different levels in the aspects of care. So we have primary palliative care, which is the incredible palliative care that primary doctors and care teams are doing every single day. So integrating palliative care principles in the single ventricle heart disease care. The subspecialty team, that I'm on, for example, is a consulting service for refractory symptom management, complex coping needs, anticipatory grief, and existential distress, as well as coordinated interdisciplinary care and complex decision making. And then home-based is really to provide extra support in the home and really for those families that are really thinking about trade-offs between comfort of quality of life, time, being in the hospital and things like that. And it does not replace in pediatric shift nursing when shift nursing is also needed in the day-to-day for regular cares because it's a palliative care at home is more of an intermittent service. Next slide. And then finally, with the Affordable Care Act, we do have concurrent care in hospice. And so even children on hospice can continue to receive life-extending disease-directed care. And so we think about this in the model of when cure-seeking care becomes unsuccessful, we provide life-extending care. And when that's unsuccessful, we provide quality of life and comfort maximizing care, and to note that for patients that do pass away from their diseases, the care does not end there, and we really partner with grief and bereavement supports as well as supports for the hospital staff when a loss has occurred. Next slide. I'll transition it over to the Lurie team to talk about their program.
Thank you so much, David, and thank you, the team, for having us here. So today we really wanted to build on this conversation and share what two centers have done in the space of single ventricle care. And so we'll be talking about the Chicago experience, and our program has been existing in this space for about 10 years, and then turn it back over to Stanford, who's just kind of getting started. Next slide, please. So at Lurie Children's, we've been really lucky to have a dedicated program kind of focused on the fetal care in that space since 2014 with two clinicians and with Grace Knowles joining us in 2017, I believe. Close enough. We function as that smaller perinatal program within a large pediatric palliative care program. As you see here, that's very much a larger team. And so we're a little tiny silo, but we are a part of a broader team. We're also functioning within the large fetal center. So again, we are a little subspecialty within a specialty, but we kind of penetrate various teams as well. All fetal counseling, not just single ventricle counseling, but really all fetal counseling is usually structured kind of surrounding all the teams that might be taking care of the pregnant patient and the baby, as you see here. And the single ventricle and the perinatal palliative care program collaboration started around 2017 with lots of conversations, lots of meetings about who are the patients we're going to see, why are we going to see them, and how will we see them. And that work is still kind of going because, again, like nothing is perfect as you first try it. And then Grace has really formally become a part of the single ventricle program just this last year, speaking to this kind of like niche within a niche and the specific kind of like needs of this particular group. Let's go to the next slide. So these are the triggers for the perinatal palliative care consult as part of the cardiac care. And you see them listed here. I'm not going to read them all. But again, these has been a work in progress for the last 10 years around what types of patients will we see. And I'll say, I think critical to that, when a fetal patient comes to the fetal center, we don't ask the parents, would you like to see palliative care? Based on triggers, we say, you will see these teams, the NICU team, the surgical team, and the palliative care team, and nobody says no. And because that is just part of the workflow, I do think that is kind of key to highlight. Let's go to the next slide. So this is kind of just part of the workflows at our fetal center. So when the first call is received, the nurse coordinator will call the patient to learn more about what they're hoping to gain from the visit. Usually they come in pretty quickly for the fetal echo and that first consult around 20-week gestation. The nurse coordinators are very good at gauging whether the family is considering I guess, kind of like the first choice at that time, if they're going to continue the pregnancy or they're maybe considering to not. And if that is the first signal, then our team may actually join that very first consult around 20 weeks gestation to help the family process that kind of particular choice. If not, if that is not an early signal, then we meet them at the first consult through the comprehensive fetal cardiac consult. And again, we join for all those patients with single ventricle, with a single ventricle, and we meet them between 24 and 28 weeks of gestation for the first time, and then often at some later point as well. Next slide. Since we're talking about fetal care, I thought this graphic is really helpful just to kind of conceptualize when parents might be facing some of these choices and conversations. So as many of you here know, your first fetal scan is around 20 weeks gestation, which is when those first calls are usually made to the fetal center. And at least in our state, the decision whether to terminate your pregnancy or not becomes semi-final around 24 weeks. So if that is a signal for palliative care consult to be a part of that process, then we will be called right around that time. But for the majority of patients, really the decisional point comes kind of leading up to birth, whether to pursue more of a hospice-directed care, and we have had some patients who have chosen that, or to say, this is our journey, we're going to start upon it and see what happens, and the palliative care team is right there with them as well. Let's go to the next slide. I'll turn it over to Grace.
So these are just some picture representations of what happens at the Chicago Institute for Fetal Health, CIFH, which is our fetal center. From that first call from the nurse coordinator who takes in all that initial information and gets some initial rapport with the patient, learning about what they've already learned and what they're hoping to learn, setting up the appointment for them to come in for imaging, and then sitting in the bottom left corner, as you can see, with a large multidisciplinary team who all have input into the care, from maternal fetal medicine specialists to neonatologists to our cardiology partners. This group model really helps us all have an interdisciplinary conversation with family and answer all their questions. Their days are very long, so you'll see in the bottom right corner, they also have a private space to wait between imaging and meetings and consultations. Next slide. So I thought it would be helpful to just overall demonstrate our volumes. The numbers aren't particularly important, but what I wanted to represent was the number of total fetal complex cardiac patients who are being seen in the center, and the growing imprint of palliative care and meeting the patients that meet those trigger criteria. I also thought it was important to highlight that our growing involvement in meeting all parents has not really swayed choices. I think some outside of palliative care sometimes worry about the inclusion of palliative care, that more people might choose a different non-intervention pathway, and really we have not seen that over time. Next slide. So once a neonate with single ventricle physiology is admitted to the CICU, palliative consult is placed to either meet that family initially if it's a postnatal diagnosis, or continue our longitudinal support if we met prenatally. This includes ongoing check-ins with parents to assess how they're managing during the neonatal hospitalization, how communication with the medical team is going, and support during any new decision points that may arise during their baby's hospitalization. And for those who need the support at end of life, we also provide that when needed. In addition to supporting families, palliative care also supports the larger medical team in making sure that they feel communication is going well, understanding the worries of the medical team and sharing how family is managing and if they're encountering any additional struggles. In 2025, I officially became part of the single ventricle team with my FTE being allocated in recognition of the amount of work that we're doing to support this patient population. This has allowed more recognition of my role as a core team member of the single ventricle group. And when patients' medical needs require transition to other cardiology services like heart failure or transplant, then we also transition and provide a really warm handoff to our much larger palliative care team, who then continues that support started during the single ventricle part of the journey throughout the journey in whatever way that might evolve. Next slide.
Thank you, Grace, for that. And like Grace already mentioned, because we're a smaller program, kind of within a larger program, we have really thought about what are the kind of necessary points of care between the fetal and the postnatal care to the broader PEDS care. And so some of that is listed here, right, like the heart failure and the VAD pathway, but also the pediatric palliative care program is very heavily kind of like working within the cardiac ICU at large based on some of these triggers that you see here. So like everybody on ECMO, everybody who's being considered for a VAD, obviously heart failure program. So our PEDS partners are also very, very kind of heavily working in the cardiac ICU space. We're also being called upon more and more as a pediatric palliative care team to support the teams, to what kind of Grace was alluding to. Some of these patients are there for months, if not longer. They cause lots of different clinical teams to ask a lot of questions about their care and the goals. So we're really trying to step into that space as well as much as we can to support the teams. We're not perfect, even though we've been doing this for almost 10 years now. There's been a lot of challenges with growth and trying to meet the needs. Obviously, lots of patients want similar faces and the providers who know them. And so within a broader, growing pediatric palliative care division, it is often difficult to meet that need. So we're trying to recreate some of our structures to make that possible. And then really, what is the footprint of pediatric palliative care in the cardiac ICU? How often do we see some of these patients? I believe at some point in time, a few years ago, on our broader pediatric palliative care census, maybe 20 patients were, kind of like in the cardiac ICU at that time. So what does it mean to have such a big footprint? Like, talking about like what are the goals of those visits? How do we work with social work, the psychology team, and the broader team? And how do we keep growing all the other parts of our division that we need to grow? So there's still lots to do there.
Thank you so much. The Lurie team just continues to be so inspiring. My name is Kelly Kirby. I'm a pediatric nurse practitioner with the single ventricle home monitoring program at Stanford. So switching gears to introduce our program and our hope to integrate collaboration with our pediatric palliative care team. So our single ventricle program here was founded and is continued to be sustained in partnership with parents. We were established by Dr. Gail Wright and Jana Norris, nurse practitioner. So quite literally, our program is built on the shoulders of giants. We are rooted in evidence-based practice, hope, resilience, and an appreciation for longitudinal optimization of quality of life. Our program is anchored in the spirit of collaboration and quality improvement, and we're guided continuously by families. We have a single ventricle family advisory council, which subsequently inspired the launch of a heart center-wide family advisory council. And we are very proud that we have a single ventricle parent mentor who is integral to our single ventricle program team. And our voices are truly united on a quest for continual innovation. We seek creative solutions to support mental health and emotional well-being for our patients and families across the lifespan. And this requires a curiosity and openness to learn from both of our successes and the inevitable bumps in the road as well. For instance, when we were so excited that we had a mental health clinician role combined with social work, and unfortunately, this presented both logistical and some difficult administrative challenges. But with that challenge, we did not break, and it further strengthened our commitment to enhance patient and family support in a variety of ways to meet as many different needs as possible. And while that was happening in parallel, since we are a silo-heavy institution, Dr. Elena Kipps and Lauren Schneider law program, which is inspired and guided by our colleagues in Kansas City, and now thankfully provides us with 2 full-time pediatric psychologists for ongoing inpatient and outpatient heart center family support. So our program continues to sort of hold this recognition that patient and family support across the lifespan requires ongoing collaboration from multiple specialties at a variety of touch points and across the continuum of care. And this requires persistence and understanding that sustainable change takes time. For instance, it took nearly 10 years of advocacy, but introductory phone calls from our home monitoring program team are following the fetal cardiology visit is now an embedded part of our system, which I'm very proud. If you could advance. And then one more time. Oh, sorry, back one. Thank you. With our voices united, our single ventricle home monitoring program team hopes to partner with our pediatric palliative care colleagues to incorporate their expertise early and often for our patients and families, beginning during the prenatal period and extending throughout the inpatient and outpatient care across the lifespan. And I'll now pass on the baton to my incredible palliative care colleagues.
Thanks, Kelly. So as Kelly had noted, we are still, my notes, in early stages of development within our integration into palliative care. Our program actually began in 2001. We were one of the first programs nationally, palliative care programs, but the program remained very small for quite a long time until we had a service line expansion in 2022 and was able to recruit a division chief of our program and medical director. And since then, the program has just continued to expand. Next slide. Oh, sorry about that. Next slide. So our clinical team is interdisciplinary in nature. It includes physicians, nurses, social work, psychology, chaplaincy, and child life specialists. Next slide. And within our kind of overarching quality of life for all program, we also work alongside integrative medicine, who provides complementary therapies such as acupressure, acupuncture, hypnosis, massage to our inpatients. And we also are fortunate to partner with our family guidance and bereavement program to allow a more seamless transition to parents, siblings, extended family members into that phase of bereavement. Next slide.
So this is just a snapshot of our growth since our program really began in September of 2023. Now having almost an average of 32, 33 consults per month. And this is across all of the institutions. So as Kelly said, change takes time, culture change takes time, and we have a lot of sick kids at Stanford Children's, both in the Heart Center and outside of it. So as you saw from Michelle's slides, that our team is quite large now, and so we really had the fortunate opportunity of growing our people, and now we're expanding out into our service line delivery. And so what I think is really interesting and notable is that 25% of our consults come from the Heart Center. This is in part due to the incredible collaborations that our kind of what we call 1.0 team had with the heart transplant and heart failure team. And so we, from our beginning, have had automatic consults for transplant and VAD evaluations. Just to orient you, our BASS Center at 17%, that's our oncology group. And then our Johnson Center at 7%, that is the NICU and fetal center. And so just as Kelly said, it took 10 years to get the home monitoring program into that fetal center kind of upstream center aspect of care, we are still working to move more upstream into the NICU, into the fetal center to provide a more seamless transition of palliative care from diagnosis, similar to how the Lurie team does it. Next slide. And just as a general concept, this is taken from a paper out of the oncology space on methods of palliative care integration throughout different subspecialties. And so right now we're mostly operating on this top rung of a on-demand consult. We're often coming when things are quite intense, using a lot of our team's resources to serve a small number of patients. For the specific population level, that's like our automatic consults for the VAD and transplant population. And this allows us to capture an entire group of patients, but the challenge is in getting more upstream and thinking about which patients might be benefiting from a palliative care consult earlier. The next step is really about the institutional level and that key concept of oozing palliative care throughout. And so that's that partnering with Kelly's home monitoring program, which in and of itself is exceptional primary palliative care. And really trying to provide bidirectional education between the palliative care team and the single ventricle program so that our ethos is aligned from the beginning in the care of these patients. Michelle, would invite you to add other context with the psychosocial.
Yeah, thanks. I was just going to add, as we distinguish between primary palliative care and subspecialty palliative care, I think it's important to note, one, that as David mentioned, there can be exceptional primary pediatric palliative care. And I think the Thrive program is just very enigmatic of that. They support the needs of children with congenital heart disease, including single ventricle, and also very interdisciplinary in nature, providing psychotherapy, parenting support, neurodevelopmental care, psychiatry, school support. And I think for patients and families who are here present with us, you all know that needs extend, far beyond symptom management, goals of care, advanced care planning, that lives are impacted, from infancy, perhaps into, adulthood. And so I think part of the challenge is figuring out kind of the who does what to ensure that families are getting the supports that they need. I think one of our growing pains is that our hospital-based programs have kind of developed in parallel. There are many different silos based on service line. And so we are in the fortunate and very unusual position of being pretty resource heavy, and yet we aren't yet well integrated into, for example, the fetal center and NICU, although we get quite a number of consults in the CVICU, and many of our infants and younger patients are admitted for surgeries. So just wanted to highlight a name that we are kind of in that process of development, especially as we kind of think about the point at which Lurie is at right now. Thank you. Next slide.
I think this is my cue. So I'll go ahead and start. So my name is Cassandra Santos. I am Morelli's mom. And so we'll go to the next slide and you'll get to see a little bit of Miss Morelli. So you get to learn about Morelli's Miracle today. And so this is a little bit about us and how we've come to work with the palliative care team. Morelli was born at 38 weeks. She was born with duodenal atresia and emphalocele and also a single ventricle lake anatomy. We spent inpatient a little bit, around 10 months, and then Morelli transferred to the Almost Home Kids facility. And then in January of 2025, after 6 months at Almost Home Kids, we made it home. And since then, we've kept her home. And so we are celebrating this milestone because this journey has definitely been very tedious, but it's had a lot of its own beauty through all the triumphs and trials. And essentially, when it comes like to the palliative care team, we came in to connect with the Fetal Institute when we after a month of having my MFM appointment, we came in and they ended up diagnosing the just everything like for Morelli with the suspicions that we had at like my first ultrasound. And May of 2023 was when we connected with the team and they shared with us what prognostics were looking like. But because we were still really early on in the pregnancy, they couldn't provide firm statistics because Morelli was still very tiny, like in utero, and we still had some like progress to do. When we were presented the option of connecting with the palliative care team, echoing what was addressed like before, it was a matter of saying, there are different specialties that are going to come into this meeting, and then palliative care was mentioned on that list. For us, logistically, we've never had this experience with palliative care team. We have no history with them. So to say that I had some form of bias, that was non-existent for us. And we ended up formulating our experience the month after when we decided to move forward with our pregnancy. Because at our original appointment, we decided that it was just too much to kind of like bear with, and we had decided to move forward with end of life. But deciding to fight for Morelli's life was and is the best thing that we have ever decided on. And we give a lot of recognition to the palliative care team because they stepped in and provided a manual where there really isn't one to kind of like walk you through. You have your hopes of going through your pregnancy and having the experiences, but when it comes to having a clinically complex kiddo, you have no idea what to anticipate for. And I lived with a big idea that, if Morelli didn't get to a certain gestational period, it just was a no intervention like policy for Miss Ma'am. Thankfully, she had other plans and we were able to move forward with everything. But we had the support of people from like Grace and Dr. Henner who sat in through every session with us, and they walked us through a lot of the logistics. They accounted for a lot of that prenatal care of, okay, like, have you and dad talked? How are you feeling? Do you need support? Are you receiving support? And anytime that the question came up to my head of like, well, what does support ideally look like? They were the prime example of what it should, and why it mattered more than anything, especially when it came to developing our goals like for Morelli throughout like her life. To provide a little bit of a metaphor, I always used the analogy when we were inpatient that we were always walking in the dark. We were always trying to find this source of hope, this source of light, to get us through this like tunnel and making sure that we knew how to navigate it. But even then, we didn't have any instructions for it. And I feel like the palliative care team kind of came in and said, you know what? I think you know a lot more than you do and you're giving yourself credit for. And I think the palliative care team did a really great job coaching us on the uses of our senses, touching our walls. What do we hear? What do we see? What do we taste during this experience? And how can we utilize that to our advantage with the backgrounds that we did to make it through? And it was just something that we've always like appreciated because it's what helped us get to the point where Morelli ended up facing her heart transplant at 6 months old, because she was no longer eligible for any of the like interstage surgeries like her Norwood or Glenn, because we decided to move forward with her GI interventions. With the help from like the palliative care team, it's helped me being the mom that I am today, that I'm always advocating and using the like fire that I have within and using the fire from Morelli to just continue to serve as a light source for other families that are navigating medical complexities, whatever that might look like for them. They've taught me to ask questions and how to consider life and just being genuine with the different point of views and the perspectives that we have. Because at the end of the day, yes, I was a mother, but I was also a daughter and I was a wife and, I was a sister. And so they had a very holistic approach with everything that we navigated. And they reminded me that I had power and everything that came when it came to decision making. Dad was always at work, and a lot of the calls had to be made by me. And my husband, love him to death for this. He trusted my very faint memory of anatomy and physiology to just navigate through a lot of the things that we were going through and making decisions for Morelli like on shot if it came to come to that point essentially with her care. The palliative care team became so critical in our life that it was a situation of okay, Grace is coming up here. Grace, so we're having a big talk coming up soon, and Fiona's going to be there, and Mary's going to be there, and then we're going to have XYZ people. Can you come? And if you can't, is a member from your team available? And in a very polite way, it's not kind of an option for none of y'all to be there, because it's important for somebody to be there and listen to the conversation, and take this information and come through and continue to support us, because when we're coming in and we're realizing all this information, sometimes we just need to take a breath. And the breath was asking a member of the team and asking them, did you hear exactly what I heard? Did you understand? And if there was something that we didn't quite grasp, can you walk me through it again? Or do you know who is able to support us with that? So they attended very important conversations like the ventricle assist device when Morelli had a BNP above 70,000 at one point. And the team said, hey, this is logistically what we're looking at. And, they sat through all of that, and it became a situation where, they reminded us of our overall goal as parents of Morelli deserves to have grace and dignity, and we only fight this fight if she wants to. If Morelli's too tired, we're not going to push her to live through tubes, lines, and drains, because we don't need to have that memory of her. We need to have the memory of her being the little beautiful girl that she is. So they sat through all of that, and they reminded us the importance of having grace and, again, dignity for our decision making. But giving that grace and dignity to Morelli at the end of the day. When we connected with them prenatally, Grace and Dr. Henner worked with me to formulate a birth plan, and they formulated a very beautiful birth plan. I still look at it to this day just to kind of not necessarily go and pick at a wound, but give me a reminder of the scar that I have with life, and a reflection that I've lived through the things that I have. And I am able to do more than that, and Morelli's able to do more than that. So they taught us how to encapsulate those first and final moments and how to grieve the situations that we were not able to live through because, we didn't get to roll Morelli out on a stroller, but we rolled her through the unit and with poles and wires connected, absolutely. But she did it, and we enjoyed the moment, and we took pictures and recorded and had that memory for us now years after the experience, because now we're a year out. So they're fierce advocates for us, because they sat through meetings where they had a very angry mom. There was a point where Lurie's communication system was hacked, and it was just extremely chaotic, and their lack of communication, even to this day, I still firmly believe that the lack of communication unfortunately impacted Morelli's overall state. And it placed her in a situation where I was having providers say, I don't know, if this is Morelli, tapping out and calling it a day. And I remember emailing Grace, and she got a very lengthy email, and I say, hey, this is XYZ, what's happening? And I'm extremely upset, and I just feel like nobody's listening to me. I feel like I'm yelling at this point, but they utilize their kind of positioning within the team to make sure that they round up the team and say, hey, something's not going right, and just making sure that during chaos, we're able to take a deep breath, sit and stand as needed, and collect ourselves, and then make sure that we reorient ourselves and put Morelli in the path of success again. And thankfully, they were able to do that. Now that we're home, we still message the team when we're in the area. We'd let them know, we give them updates, because it's extremely important that they get to see these beautiful things with us and celebrate these things, because this is just as much their journey as it is ours. Next slide, please. And so this is Morelli's world. We have this hanging up in our living room right next to her crib, and it's an ongoing reminder of the 10 months that we lived in the CCU. The letters were hanging up in her room. They were colored by the nurses, and so it's a reminder that the darkest of times, we have to have a little bit of color and a little bit of shine. And every picture that's up there of Miss Morelli is a picture of every month that she made it her first year of life. And even if she has a CPAP, if she has an endotracheal tube, whatever that might be, like, we put it up there because it's a reminder that she did that, but she did that because she has amazing parents that are behind her. And yes, I'll toot my horn on that because it's a lot of work trying to keep a trach vent kiddo alive. And then we have these signs that are posted under there. And so they're a very gentle reminder that no detail is too small to make sure that the picture is always perfect for us. So anything that when it comes to her care, we're always reminded of where we started and where we still have to work through because this is a for life thing, or until Morelli decides so, essentially. And this is just a little picture of her heart, actually, from the time of birth. This was what was posted in her room, and so we just keep it as a memory, and it does hang up in our living room as well, right below her heart transplant picture date. So we're extremely excited about that. Overall, with the palliative care team, I think it's critical for parents that are in this room to advocate fiercely for yourself and have a support system at your facility, and asking them, hey, I need a third party professional coming in and listening to the conversations, because I need to make sure that these big medical terms that these doctors are utilizing, I'm not understanding. And that's a big word for Elmo, as we say in my house. And I need somebody to simplify that, and I need somebody to walk me through it. And that's what the palliative care team did for us. And for those professionals that are already in the healthcare team, it's important to have that kind of support, because when you don't know necessarily how to navigate these conversations with the patients that you're working with, you have somebody that is able to help with that decision making and maybe help you feel more comfortable when you're behind the surgical table or signing off on paperwork, whatever that might be in your situation. But it's really about the empowerment of the patient and the caregivers that are there with them. The palliative care team showed us that everything and everyone deserves grace and dignity and boundaries. It was what helped us literally sleep at night, because when I said bye, I'm going home to sleep and I'm going to pump, don't call me unless it's an emergency. And the only time I was ever bothered was 2 days before Morelli's transplant, that I got the call at 3 a.m. letting me know that Morelli had to get paralyzed and sedated because she was having severe bronchomalacia spells. Otherwise, as a pumping mom and a mom that was trying to fight every single day, I slept and I got whatever beauty sleep I could. And that was important for me. But that's also thankful to the help of the palliative care team. And the palliative care team is the reason why I say everybody needs help. Nobody can do these things alone. It really does take a village. And so I genuinely invite people to really start challenging their facilities and asking them, are we truly doing everything and anything for our patients? And to think that at one point we didn't know if Morelli was going to make it alive. Now we're at Ross, loving ourselves and walking around and licking mirrors and, just living to the fullest. So thank you so much. And on to the next slide, and to whomever's next.
Right. So now we're going to talk about some future directions and some Q&A. We can move on to the next slide. So I'm going to say first that I'm actually going to be very brief over the next 2 slides, because I'm really interested in getting people's insights and thoughts after all the discussions that we've had, or I should say, all the information that we have shared with you all. And you may be wondering, well, what now? What do I do at my institution, and what do we do as a community at large? And these questions are questions that many cardiology adjacent individuals have been asking themselves actually for quite some time. And so for me personally, one thing that I have taken away is that we really need to strengthen our primary palliative care skills across disciplines in the cardiac center. And I think about that from all levels. It's not just the surgeon, it's not just the ICU attending or the fellow. It really is our nurses, our PT and OT, our speech therapists, our RT. These are the individuals who are at bedside day in and day out and every single minute. And strengthening and giving those individuals the ability to support our patients and their families is so key in this effort. I also think about expanding access across the lifespan. We've talked a lot about the perinatal and the fetal support that the palliative care can provide, as well as support in certain clinical situations, such as when the patient is undergoing transplant evaluation or VAD. But I also think about patients and their families as they move into their adolescent and young adult age. We all know that congenital heart disease or cardiac disease does not stop at the hospital door, right? It's at school, it's in the playground, it's going to be at the dance recital, it's going to be at the basketball game, it's going to be at prom and graduation. And so thinking about how to support these patients through those transitions is really important. And particularly, I think that a palliative care lens allows families and patients to think about difficult decisions when it comes to self-management, and also who is going to be able to support me when I'm 18, who's going to help me make those difficult decisions, because that's also not going to stop all of a sudden where an adult is an 18-year-old is going to be expected to make these really challenging decisions on their own. I think even we as adults turn to our families and friends when we have to make difficult decisions for ourselves. Next slide, please. When it comes to research, so at our individual program, we are hoping to do a retrospective look at our perinatal palliative care program. And then I think at large, we really need to do a better job of thinking about what are the outcomes that are most important, not only to our patients and parents, but also to the medical and surgical team as well. And I see that, the 1 minute end, and to think about outcomes that are pragmatic. And I'm going to stop there and see if there's anything else, thoughts, questions that come up.
We had some questions to stimulate conversation, and I'm hoping that maybe some folks might be able to either chime in the chat or come off mute and highlight any sort of big wishes as you've heard these conversations about palliative care.
One thing I was going to ask, actually, so we know that we're the biggest collection of single ventricle patient, we have the largest registry. Our registry essentially doesn't collect any information about this, as Michelle mentioned early on, which I thought was kind of surprising and maybe a missed opportunity. I would be interested, one, because there's not that much time for a discussion, but for everyone who's on this breakout, can you just put in the chat what your center does from an interface with palliative care standpoint? There was a multiple choice sort of version of that, but I think this is one of the things that we're trying to understand, and that we as a network have an ability to understand systems of care in a way that isn't really possible necessarily any other way. And this is a clear selection bias. You're in this talk, so you probably think this is important. So I recognize it's going to be a little skewed. But I would just be interested to know, do you have a concrete systematic interface with palliative care? Is it triggered just by concern? Do you not have any access to that at all? What is the landscape that we're all interacting with? And that's been a conversation we've had in every one of these initiatives so far, right? Liver health and neurodevelopment and all of those. I think one of the things we've really tried to do as a network is understand that it doesn't necessarily matter. You don't have to be rigid about how you put it together. You do have to be thoughtful about what you're trying to deliver. So it may be that you are never going to have access to palliative care specialists, but somebody has to do that job. So who's it going to be? Is it you as the primary cardiologist? Is it a social worker? Is it your nurse coordinator? Who is it? I think that's a lot of what we need to sort of establish. What do we think is the minimum that the patients and families deserve to be well supported, and then think through how do you deliver that within your own institution in a way that's realistic for you. So just something to think about, and maybe people would want to unmute and talk about, but it looks like people are posting in the chat now too.
We probably have about 1 more minute until we have to close the breakout room. I just want to jump in really quick if there's any final thoughts, but we'll have to close the breakout room here in about 1 minute for the break.
Yeah, I do think I will just say, I like to think of myself as someone who has a fair amount of palliative care counseling expertise, and it was insufficient in the case of Morelli. Like I put this in the chat, but like we needed an ombudsman at times. Like there were things that Cassandra had to say that were hard, that it was hard to say to me because I was invested on multiple levels as an ICU provider and as her primary cardiologist. And there were times when she was literally dying and like she had things that she needed us to understand that it was harder to say to me and she needed a go between. So I do think, like to Erica's point, we all have to have this skill set, but there is something to be said for having a third party that can provide something that's a little bit separate from the intensity of the daily care.
All right. Well, thank you guys for such a great presentation. I know this was a difficult and sensitive subject, and I think a lot of people learned a lot during this call. So thank you guys for the great presentation.